Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Bara, and today I'd like to give you some feedback on the Halfday Releases lecture series, the Practical Resident-Based Teaching Program. It has been absolutely our pleasure to give this to you. The idea was to present cases and to discuss those cases in the form of approach. And so we did this survey number 1, which is to see the response of the residents towards the cases and whether they would like to continue doing them or no. Admittedly, we got incredible response in the sense that there's a lot of ways that we can improve this. And the most striking things or notes that we have noticed are the fact that we should focus more on specialized cases or things that we don't see in the morning reports or on daily basis. And we received the want to kind of make things slightly more complex so that we can have more benefit from the cases. Which I think makes sense, because as me and some of my colleagues have been going to do outside rotations outside of KSMC, we noticed that they do have the access to more tertiary cases. And to the contrary of what people think, in our hospital we do have a lot of tertiary cases and a lot more exposure than other hospitals. It's just we don't always get the time to discuss them in the sort of details that the other hospitals do. You see, in our hospital, the service aspect is large and exposure is large, so that's the benefit. The downside would be that you don't have as much one-on-one discussions and teachings, and we're trying to ameliorate that difficulty or challenge by the Practical Resident-Based Teaching Program. First of all, thank you for your feedback. And second of all, it's great that we got 40 responses, which represents 60% of the residents that are, more than 60%, about 61 or so percent, which was deemed statistically significant so that we can actually have proper feedback. And we got that within a week, and I think that's nice, especially that the survey was slightly long. We really apologize for that, but we needed to get your feedback on those points. All right. This is clearly not going to be statistical analysis, because we're actually going to go through our statistician, who's a professor who worked in statistics for a long time and will be helping us towards analyzing the data and using all the right formulas and doing the proper data analysis. I don't want to do that. But we are working for the program and with the program. We are residents, you are residents, and you were kind enough, and we really appreciate that you answered these questions, and we'd like to be transparent and give you the answers as they are. So we're just going to look at the raw data, and I'm going to tell you as we go through this list what questions will actually be interpreted and which things are turned out to be poor questions that we're likely going to exclude. But before we exclude anything, I just wanted, for the sake of complete transparency, give you that, and hopefully we'd like to get more feedback from you as they come. Just send us your emails or text us. You know, I mean, there's really no barrier. We're just colleagues. Anywho's, so most of the R1s have responded. Some of the interns that attended have responded. Exactly 3 interns, and we had 4 interns who attended, who were rotating in the Department of Internal Medicine, and 1 intern heard about it and came from outside the department, did not actually rotate in our department. And we had 10% of the R1s, 17% of the R3, and 28% of the R2. And that percentage is of the total emails that were sent. So approximately we sent to about 120 emails, but we have a total of approximately 70 residents, and so not all of them are required to attend the half-day release, and so approximately 60 residents have to attend the half-day release. The exact numbers you will find with our department secretary and coordinator for the program, but the idea is just to get a visual of what this percentage means. And so these are the sorts of things that we will adjust in the data analysis. We have some of the residents who have some years of experience, but half of them, more than half, because those who, more than half, or half of them did not have any previous experience whatsoever before joining the program, and half the rest of the compilation have some experience prior to the program. The majority of the residents want an interactive case presentation to variable degree of likeness, and very few didn't want, and it's kind of like a homogeneous amount that don't want it. In general, most of the residents want interactive lectures, whether they're an actual lecture or case presentation. In general, most of the residents would suggest half-day release attendance, and especially for the practical resident-based learning. Most of the residents think that we should limit the half-day release to 3 o'clock, which is reasonable. If we start at 12 to 3, that's enough time so that you retain attention span. I tend to be personally of that preference, and so we can have enough time with retention of information without overload, and then we can actually be enthusiastic or interested somehow to go back and read about this stuff. Some of the comments, obviously this is anonymous, so we don't know who wrote what, but I'd like to read the comments for you. So the first comment suggests that it's 12:30 to 3 p.m. is good, and that the administrative time should be done outside of the half-day release. And one person just says 3 o'clock, another 2 hours maximum. We have 2 people who want 2 hours. One person says 3 hours is acceptable, up to 3. So most people agree with up to 3. 1 to 4 is pretty enough. I think our half-day release should start early morning, and after that we can join our teams. It's an interesting and radical suggestion, which can be difficult with the consultants, but I don't know of another hospital that does that. But it's a valid thing when you think about being focused and sharp. You're focused and sharp in the morning. 12 to 3 again. One of the residents says, I think we should correlate the time with planned content. However, the time should not exceed 3:30. So this is like a flexible suggestion, which is nice. The benefits are more important. Also, we can give an extra time to those who are interested, which is actually nice. So say there are parts of a case presentation that not everybody would like to attend. The videos, I found that people are not really interested in the audio visuals as much unless we give them something more complex than the simple osmosis videos and things like that we start as an introduction, even though they are very short in time, like 10, sometimes up to like 15 minutes. But they're more interested in maximum benefit, which is respectable. These are very smart people. They're physicians. Their time is valuable. And I wish that we start valuing the time. 3 hours is enough. From 12 to 4, one person is suggesting to go all out and take the whole time. But that's an outlier. So we have one person from 1 to 4, one from 12 to 4, one from 1 to 4, and the rest are suggesting to 3 or 3:30 maximum, with one suggesting of having the administrative activity in an outside time, and one person suggesting that the half-day release be done in the morning. And then one resident says, I think the point is not enough in the length of time, but in the benefit. Putting the activity as part of the day work and the day work will help there. So this is another person who's addressing the idea of putting the activity in the beginning of the day will help the resident to escape. Also, they will attend with low concentration. It's okay to put in the beginning of the day, morning. So yeah, so this is another resident that's rationalizing why we must put it in the beginning of the day, which is actually an interesting rationale. The practical resident-based teaching program is done at a professional level in terms of preparation. So this is like a parabolic graph. Most of the residents think it's done in professional. There's like a little peak in the middle where 4 of them think that it's not. It's half-half. They're like in the middle about it. Next question. In general, I prefer to study at home rather than 10 half-day release. This is, you cannot really draw statistical significance, even though some of them are clustered in the lower, but it's a kind of a jigsaw graph. And of course, we're going to analyze that statistically, so we know for sure if this is giving us a statistical significance or not, but I'm inclined from the graph to say no. I think the half-day release is not beneficial, and they would rather attend, and if I had to attend, I'd rather attend a case discussion instead of a lecture. This is one of the questions that's controversial, and our statistician was unhappy with it because it's a complex question. So this means that you have to agree that you don't like the case, but if you had to, you'd rather attend a lecture, and in that case, you would be a 10. But if you want to attend anything, then you'd be 0. And if whether or not you like the case, so this question is probably going to be excluded completely from the statistical analysis. But it's there for your information, for transparency's sake. I enjoy discussions in social situations, so you have that as well. Most of the residents do, and that's really gives a lot of hope, because you're an internist and you deal with a lot of social situations. And if you see that most of us want to have discussions and be in social situations, then it makes a lot of sense to have our teaching program based on this model, based on actually discussing and being able to freely kind of ask our questions and get feedback and ask more questions and inspire more discussion, which is where we wish to lead the case discussions. And to us as the team, we have outlined a number of deficiencies which we will present formally in a poster and we will hopefully publish in a paper, so that we can actually formulate a scientific opinion on how to intervene with our teaching so we can continue. The purpose of this is not a research, it is not a transient project. It's more like a campaign to ensue change. And so we genuinely beg you and hope that you, if you don't like it, don't resist it, but rather come and tell us why you don't like it so we can improve it. And so some of the challenges that we have noticed is that, in fact, the cases need slightly more preparation to spark better quality discussion. Sometimes we feel that we go all over the map and the questions are neither targeted enough nor do they spark general discussion in an area. Like, for example, when it comes to counseling a cancer patient, we kind of went all over the map in one of the cases that we did. And so those are real concerns, but we are growing with you. And so God help us, give us your feedback. And we're kind of doing this analysis or feedback amongst the team, and as well as the academic committee, as well as our program director, and trying to improve the state. Here is a question to ensure people were actually answering the questions. Spain is the capital of Dubai. If anybody put any number other than 1, which is completely not true, 1 is not true and 10 is very true, then that means that person needs to be excluded from the analysis. And so it means 40 people actually answer the questions properly. I prefer didactic, not interactive lectures and find them to be more beneficial. Most people disagree, but it is interesting to note that there are 6 people at 8, 3 people at 9, and 4 people at 10. So yes, some people still prefer didactic, and it makes sense. Why? Because we want, and even myself and some of my colleagues, and also from the discussions of my mentors and teachers and professors, including my program director, who was asking me, are we sure that we don't want to actually give all the points that the residents need? Because the idea is to make sure that we pass our exams while being safe doctors, and we want to be sure to cover all the material. And when you're getting an expert who's giving you a didactic lecture, a senior consultant, they will be covering all of these materials. And that is a real question, as opposed to having a case discussion and it's a problem-based, resident-based teaching. And in that sense, you have that issue. So we were thinking that instead of putting an audio visual, maybe we can get an expert consultant to give a presentation about how to approach a case, then discuss the case, and then after it, the consultant will actually give you the presentation of the answers. And that way you kind of cover it all. And so this is a proposal for you. Give us your comments and your feedback. Next question, I'm aware of the academic activities in terms of announcement and receiving it in time, so people are aware. I am motivated to study and would usually attend academic activities. Most of the residents have this internal drive, which is great. And so when you see people not attending, but they have the drive, it means there's a problem in the activity. There is a problem. The problem is not in the residents. The residents are telling you, I want to attend, regardless. The main reason I attend the half-day release is because attendance is mandatory. I was shocked. I mean, honestly, I thought we'd have more, but this is fantastic. People are telling you no. And this is anonymous. You can't tell. This is validated by email, but you cannot tell from the data presented who is telling you what. I always found the half-day release time to be of scientific benefit and helped me towards my exams and clinical practice. So the majority of people say yes, but again, there is a spike in the middle of indifference, and there are a few people that found it not to be. And when we do the data analysis, because we have the data, we're going to extrapolate, for example, how many R4s or R3s, the seniors, for example, is it the seniors that find this not useful because they actually want further, like higher quality information and more complex, and they want focused time, they don't want to waste their time, and if so, how can we serve them? So we still have to go to the data analysis and find that out. I found that my clinical approach to patients has improved after attending the practical resident-based teaching program. This is all over the map. There's a tendency towards the end. There's some central tendency, and there are some people that find it not to be beneficial in terms of the approach. And this is very important because we're not only focusing on the academic activity, which is the academic teaching, the facts, the science, the information, but also to approach, because our objective was to be a safe doctor who knows how to approach the patient safely. And so luckily, many of the residents find it improving their approach. Again, I'd like to know, as you would naturally, anyone who'd see this graph would like to know how many of the R4s and R3s. So we'll do that data analysis, and hopefully in the formal presentation and the paper publication, you'll find that extrapolated from the raw data. I find the HDR, which means half-day release, beneficial, and the case discussion to be especially of benefit. So there's a central tendency towards the positive response. The educational, the practical resident-based is an educational intervention, stimulates my thinking and encourages home reading. Most people find yes, and that is the goal. This is exactly the goal of this intervention program. My patient approach skills have improved after attending the half-day release in this academic activity. So this is kind of a internal validation. Two questions that ask the same thing, and again we get the same. There's some tendency towards more, but then there are also people who find it not, and so we'll analyze that for which group thinks that, so we know which group is benefiting most and which group of residents is not. And even if we find that some of the younger training year residents are finding it to be not, we'll see how many years of experience they have in the past. So this is going to be a beautiful objective data analysis. I found the half-day release to be safe and non-judgmental environment for discussion. That is spot on. This graph is wonderful because this is something that ensures high quality discussion. We should cancel the lectures and make our learning problem-based learning only. So this is an absolute no. That means from now on we're going to have hybrid case presentations, and that makes a lot of sense. This way you can cover a lot of ground, facts through the didactic means, and discussion to spark understanding of the guidelines and practical issues. We should do didactic lectures only. This is to ensure that this is what people want. So most people don't want it, with some people that want that, and that will be analyzed, but mostly people like to have non-didactic lectures, and that you see clustered from 1 to 5, 1 to 4 being pro cases and interactive activity. I enjoy video simulation and non-visual. So again, many people want, but there are many people that don't, and so we can actually try we can actually try to make the videos and lectures more complex in nature, so that to increase benefit. Preferring hybrid modality, most people do. Wonderful, I do too. Benefited from feedback of the consultant supervisor for my writing skill, the plan, the order sheet, the progress note. Awesome, yes, and that is great. That means that the cases are actually doing some of the things that they are meant to do. I feel driven to attend when a case is announced. That's great. I think we need more audio visuals in the cases, so most people don't care. And then on either side, that's why it's a place where we can play with. So our suggestion is we want audio visuals of higher quality and more concentrated knowledge, and we really need your feedback. The last two questions are questions that again are slightly complex and partially mutually exclusive, and our statistician was very unhappy with them. We might have to remove them or try to analyze them in a more simplistic way, but most of the people think that we need some changes. Ideally, if someone found that minor changes are needed, they should find that major changes are not needed, but the same people are answering the same levels in the different questions as per the raw data analysis. And so when we come to present this, we'll discuss the power in terms of these two and explain when and what we might incorporate. That doesn't matter. That being said, we have people telling us they like the case and they want it to improve, and that is great. So we have the final feedback. So tell us how to improve. Some people are telling us keep going forward. Thank you very much. And Some people are suggesting once a month and the rest didactic so that they ensure local speakers. And so we're either going to do something like that, or we're going to incorporate the lecture itself, like a shorter case with a hybrid lecture, or a lecture, preferably a lecture that is related to the case, or the case tailored towards the lecture, involving the consultants earlier on. And we're going to grow. This is like a milestones. We're in the infancy. We're going to grow step by step. Should be discussion from 12:30 to 1 and lecture and about the case we discussed. That's an interesting way to put it. I think discussion of the case may be too short here, but then again, this will be open for the team to discuss and see what's best. We want the attention span to be retained. We should present it by consultants only, otherwise it is better to read at home. So these are people who are not happy being taught by their colleagues. None of the cases are prepared exclusively by the residents alone, and cases are always corrected and then presented and supervised by the consultant supervisor. So you should be resting assured regarding that point. And we will have more involvement of the consultants based on your feedback. So thank you for giving us your feedback, and we need more. Most important to take experience from the consultants. Other colleagues need interesting lectures like KFSH and RC. So our colleagues in the academic committee are working hard on getting the highest quality speakers that we can possibly get, so external speakers. And we have been doing that for the past few months. And we started the ACG lecture series, and so this is about the same time that this feedback is coming in, and we're actually actively already responding to your feedback. I hope you realize that, because we are listening to your feedback. And we need, one of the residents says, we need, as I think, consultant-based lectures from each subspecialty, and we can discuss cases after that with or without consultant supervision, and need clinical sessions. Someone says no improvements are needed. Thank you very much. But we believe there are always improvements possible. And also other people are thanking us for the cases when they're very impressive and helpful. But the meeting room in the fourth floor, so this is an interesting suggestion. Meeting room in the fourth floor is not suitable for group discussion, as it is designed for conducting lectures. So they'd like to have round tables and things that facilitate group discussions. Consultants. So there are a number of people that want higher role of consultants. So we'll definitely incorporate that for sure. And also pathophysiology and pharma. Interesting. We're lacking in that department. We'll try to incorporate more clinically relevant basic science. That's a great suggestion. I think we should avoid the classical lecture, sitting in a chair. That is definitely the whole. So it seems everybody agrees. Everybody is clearly agreeing that they don't want the classic sit in chair and sleep didactic lecture. The only discussion is how much do we want it to be exclusively resident based, or we want consultants. And right now it seems the conclusion is the cases are great, we want to continue, but we want a higher role of consultant and we want more benefit. And that's nice. So we're going to work on more benefit. That was the raw data analysis or raw data presentation, just as it is, full transparency, with commentary on how we're interpreting them. You may feel like you want to interpret them in a better way. We're definitely going to do the scientific, objective way of analyzing the raw data, using the scientific methods with a statistician. But once again, please, we're taking your feedback. We're listening to it. We have made changes based on your feedback. So we ask you to continue to give us your feedback, what you think we do right and wrong. This is your training, not just mine. I'm working for my training. Our colleagues are working for their training, and under the supervision of our department chairman and our program director. The program director has been very keen and gave us this freedom to do what we want, and both the department and the program are insisting on our attendance to the half day. And so let's make the most out of it, and thank you very much.